Today I will be talking about MRI of knee, ankle and the hip. And before I will go in detail about each one of them, I'll just want to say that what is kind of similar to all three of those MRI scans. First of all, it's a setup. We are doing the setup for those three: knee, ankle and hip. Nothing different from any other MRI. We still need to wipe everything clean. We lower in the table, clean the table, wipe the scan board. And before that, we were actually walking into the zone 4 MRI scanning zone. We demetalize ourselves, emptying our pockets and taking off any watches, any devices, no phones allowed, no loose metal. And also we position the patient supine in all three cases, and most of the time we're doing feet first, which is a good news for claustrophobic patients, because for most of them it's not that traumatic experience just to go feet first, because their head is out, and it's kind of give them peace of mind for most of the time. The only thing that some facilities, we don't know, sometimes they prefer going head first for hip, but this is a questionable thing, because the hip is kind of like a mid body area, so that's why we can have like different ways doing that, like head first or feet first. But for knee and ankle, we put the patient feet first. So let's talk about knee MRI. If we are in a position to choose, that means we have coils to choose from, we will choose the most high definition one. It's 8-channel coil. It's a kind of like dedicated knee coil, or a chimney coil. To be honest, each facility probably have only one of those, so that it makes it easier for us. We don't even have to choose. In case we have an extremely large patient and there is no way we can fit the knee in one of those coils, not a problem. We can use the torso coil. We just wrap around that coil, wrap around the knee of the patient, and secure this with stripes so it doesn't slide, doesn't move. However, it will cost us, because torso coil will not give us that good of signal to noise ratio. The laser mark for the knee is pretty straightforward. It's apex of the patella, and it's very easy to see. It's like the bottom of the knee, there's a bump. So this is our landmark. For the axial sequence, we use coronal plane to plan our sequence. First, we run localizer, which is taking us 45 seconds. It's just a low resolution image. It just shows us the approximate position, see if we cover everything. Everything is good. So angulation is also pretty straightforward. We have two condyles of the femur. It's lateral and medial, so we go parallel to them. Slice coverage, from the tibial tuberosity up to the line of superior patella. We have to include tibiofibular joint. Now let's talk about sagittal. For the sagittal plane, we use axial plane. Slice angulation is parallel to lateral condyle. It's actually visually really distinct, kind of straight line that's really hard to miss. Of course, this lateral condyle is a lateral condyle of the femur. And slice coverage from one condyle to another, from lateral to medial. For coronal sequence, we use axial plane. Slice angulation, again, our friends here, medial and lateral condyles of the femur. So we're going parallel to medial and lateral condyles of the femur. Slice coverage from anterior of the patella, meaning from front of the patella, to the line of the popliteal artery. One important thing is necessary to mention here, because we pretty much can not get away without saturation bands in that case, because we have way too huge of the blood flow in that area. So a saturation band we put on top or on the bottom, meaning superior and inferior in the image. Hopefully that will eliminate the blood movement artifact in all images. We try. Ankle MRI. Like everything else, ankle MRI is no different. Everything has to be cleaned, wiped, disinfected, organized. We cannot come in without checking ourselves for not compatible MRI items in our pockets on our body. And we change the linens again. We make sure everything is neat, the table is lowered down, the coil is ready, also wiped, clean, disinfected, plugged in. And I will be talking about MRI of the ankle, not to mix it up with MRI of the foot. The MRI of the ankle has a special name. The MRI of the ankle is a hindfoot. And it is very important for us to have small field of view because of the tiny details and anatomy in that area. So we have to be very specific with our field of view to make it as small as possible. We make it as small as possible for the better imaging results. The wonderful coil for ankle MRI is chimney coil. What if we don't have chimney coil? We can use some head coils for that MRI. However, we have to make sure that the toes fit. It is very important once the foot is placed in the coil to pack it very tightly with cushions, so patient cannot move it very easily. Some patients also like to wiggle their toes. We want to prevent them from doing that also with the cushioning. No exception, like I said at the beginning, the patient will be placed supine, meaning on the back, and feet first. There's one detail here, it would be very useful to dorsiflex ankle. The visual landmark is pretty obvious. We have two bumps on the inner and outer sides of our ankles, malleolus of the ankle, so it's medial and lateral. Inside in anatomy, it would be a mortise joint, but we cannot visually see it from outside. For the axial sequence, we use coronal plane. Slice angulation parallel to the mortise joint. Slice coverage from the tibio-talar joint all the way down to plantar aspect. For the coronal sequence, we will use axial plane. At this point, we will use, again, slice angulation malleoli, but that's going to be perpendicular this time. Slice coverage would be from Achilles tendon to the midfoot. For the sagittal sequence, we will use axial plane. Slice angulation will be parallel to the lateral and medial malleoli. Slice coverage pretty straightforward from one malleoli to another malleoli, so from medial to lateral. For the hip MRI, again, we want to prepare our coil first of all. That's going to be torso coil, but as well, we will not walk in zone 4 without demetallizing ourselves and check ourselves for the items that not allowed and not compatible with MRI zone 4. Everything wiped, the linens changed, table lowered down, and all the surfaces I wiped, like a board, table, everything, doorknobs, what we touch. And coils prepared, plugged in. Like I said, it's a mid-body, and we have a choice here to put the patient supine head first or feet first. But oftentimes patient goes feet first in this particular MRI. Some sites require patient feet to be inverted. That means the toes kind of like taped together. That's totally fine. We just have to make sure that we put some barrier, some little cushioning between the toes. The laser landmark is the hip joint. Actually, we can do this trick without touching the patient. We ask the patient to bend the knee for a short bit, and we'll see where this angle starts between the leg and the body. That's going to be our visual landmark. We use coronal plane for axial sequence. The slice angulation is parallel to left and right femoral heads. Slice coverage from anterior superior iliac spine up to lesser trochanter. For the sagittal sequence, we use coronal plane. We're doing only one side, one if there's a hip affected or thigh affected. We don't do on this plane both sides, both hips, only affected ones, or else it's going to be enormous amount of area at the same time. If the patient came for both sides, we will do sagittal separately for each side. Slice angulation parallel to the femur. Slice coverage from hip joint, from the outer cortex of greater trochanter up to the inner portion of acetabulum. Our coronal sequence of the hip, we plan on axial plane. In this case, we have both hips in the field of view. Slice angulation parallel to the left and right femoral heads. Slice coverage from the ischial tuberosities up to the line of the pubic symphysis.